previous courses, we introduced causal inference in epidemiology. Today we will address several additional issues that need to be considered in deriving causal inferences from epidemiologic studies. In this chapter, we continue the discussion of causation that was begun in last class. Our discussion here focuses on three important issues in deriving causal inferences: 1. Bias, 2. Confounding, and 3. Interaction. Bias has been defined as any systematic error in the design, conduct, or analysis of a study that results in a mistaken estimate of an exposure's effect on the risk of disease. Bias mainly includes selection bias and information bias. What types of bias do we encounter in epidemiologic studies? The first is selection bias. If the way in which cases and controls are exposed and non-exposed individuals were selected is such that an apparent association is observed, even if in reality exposure and disease are not associated, the apparent association is the result of selection bias. One form that selection bias can take results from non-responsive potential study subjects. For example, if we are studying the possible relationship of an exposure and a disease, and the response rate of potential subjects is higher in people with the disease who were exposed than in people with the disease who were not exposed, an apparent association could be observed even if in reality there is no association. In general, people who do not respond in a study often differ from those who do in regard to many demographic, socioeconomic, cultural, lifestyle, and medical characteristics. Since in many studies no information is obtained from the non-responders, non-response may introduce a serious bias that may be difficult to assess. It is therefore important to keep non-response to a minimum. In addition, any non-responders should be characterized as much as possible by using whatever information is available to determine ways in which they differ from responders and to gauge the likely impact of their non-response on the results of the study. Another type of selection bias has been called exclusion bias. It results when investigators apply different eligibility criteria to the cases and to the controls in regard to which clinical conditions in the past would permit eligibility in the study and which would serve as the basis for exclusion. It is important to keep in mind the distinction between selecting subjects for a study and selection bias. Virtually every study conducted in human populations selects study subjects from a larger population. The nature of this selection potentially affects the generalizability or external validity of the study, but does not necessarily affect the validity of the comparisons made within the study or the study's internal validity. On the other hand, when a systematic error is made in selecting one or more of the study groups that will be compared, selection bias may result. Such a bias can result in odd ratios or relative risks that may not be correct estimates and consequently lead to non-valid inferences regarding associations of exposure and disease. Selection bias is therefore an error in selecting a study group or groups within the study and can have a major impact on the internal validity of the study and the legitimacy of the conclusion. But the virtually universal need that arises in designing and implementing any study to select a study population from a larger referent population should not be confused with selection bias, which results from a systematic error in selecting subjects in one or more of the study groups, such as exposed or non-exposed, or cases or controls. Information bias can occur when the means for obtaining information about the subjects in the study are inadequate, so that as a result some of the information gathered regarding exposures and/or disease outcomes is incorrect. Given inaccuracies in methods of data acquisition, we may at times misclassify subjects and thereby introduce a misclassification bias. For example, in a case control study, some people who have the disease cases may be misclassified as controls, and some without the disease controls may be misclassified as cases. This may result, for example, from limited sensitivity and specificity of the diagnostic tests involved or from inadequacy of information derived from medical or other records. Another possibility is that we may misclassify a person's exposure status. We may believe the person was exposed when the person was not exposed. Or we may believe that the person was not exposed when, in fact, exposure did occur. If exposure data are based on interviews, for example, subjects may either not be aware of their exposure or may erroneously think that it did not occur. If ascertainment of exposure is based on old records, data may be incomplete or inaccurate. Misclassification may occur in two forms: differential and non-differential. In differential misclassification, the rate of misclassification differs in different study groups. For example, misclassification of exposure may occur such that unexposed cases are misclassified as being exposed more often than the unexposed controls are misclassified as being exposed. This was seen in the hypothetical example of recall bias presented in the discussion of case control studies. So a differential misclassification bias can lead either to an apparent association even if one does not really exist, or to an apparent lack of association when one does in fact exist. In contrast, non-differential misclassification results from the degree of inaccuracy that characterizes how information is obtained from any study group, either cases and controls or exposed and non-exposed persons. Such misclassification is not related to exposure status or to case or control status. It is just a problem inherent in the data collection methods. The usual effect of non-differential misclassification is that the relative risk or odds ratio tends to be diluted and it is shifted toward 1.0. In other words, we are less likely to detect an association even if one really exists. Some of the types and sources of information bias in epidemiologic studies are shown in this slide. Bias may be introduced in the way that information is abstracted from medical, employment, or other records, or from the manner in which interviewers ask questions. Bias may also result from surrogate interviews. What does this mean? Suppose that we are carrying out a case control study of pancreatic cancer. The case fatality from this disease is very high and the survival time is very short. When we prepare to interview cases, we find that many of them have died and that many of those who have survived are too ill to be interviewed. We may then approach a family member to obtain information about the case's employment history, diet, and other exposures and characteristics. The person interviewed is most often a spouse or a child. Several problems arise in obtaining information from such surrogates. First, they may not have accurate information about the case's history. A spouse may not know the work-related exposures of the case. Children often know even less than do spouses. Second, there is evidence that when a wife reports on her husband's work and lifestyle after he dies, she tends to elevate his occupational level and lifestyle. She may ascribe to him a higher occupation category than that in which he was actually engaged. She may also convert him posthumously to a non-drinker or non-smoker, or both. If a population is monitored over a period of time, disease ascertainment may be better in the monitored population than in the general population and may introduce a surveillance bias, which leads to an erroneous estimate of the relative risk or odds ratio. For example, some years ago a great deal of interest centered on the possible relationship of oral contraceptive use to thrombophlebitis. It was suggested that physicians monitored patients who had been prescribed oral contraceptives much more closely than they monitored their other patients. As a result, they were more apt to identify cases of thrombophlebitis that developed in those patients who were taking oral contraceptives and who were therefore being more closely monitored than among other patients who were not as well monitored. As a result, just through better ascertainment of thrombophlebitis in women receiving oral contraceptives, an apparent association of thrombophlebitis with oral contraceptive use may be observed. Even if no true association exists, recall bias operates to enhance recall in cases compared with controls. Thus, a certain piece of information, such as a potentially relevant exposure, may be recalled by a case but forgotten by a control. A related type of bias is reporting bias, in which a subject may be reluctant to report an exposure he is aware of because of attitudes, beliefs, and perceptions. If such underreporting is more frequent either among the cases or among the controls, a bias may result. A point to remember here is that bias is a result of an error in the design or conduct of a study. Efforts should therefore be made to reduce or eliminate bias, or at the very least, to recognize it and take it into account when interpreting the findings of a study. However, the data needed to document and assess the type and extent of bias may not always be available.